Hi, everybody. I'm Annalee Cawthorn with the Tennessee Commission on Aging and Disability. We serve as the state unit on aging, which provides administrative support to the State Palliative Care and Quality of Life Advisory Council. I'm so happy to introduce our speaker for today, who's Karen Hyden. She's going to be providing today's webinar. Karen Hyden is a nurse practitioner and National Palliative Care Clinical Director for Compassus, where she helps launch, grow, and sustain community-based palliative care programs nationally, as well as train and mentor the nurse practitioners. She is a board member for the Hospice and Palliative Care Credentialing Center and a technical expert panel member for the development of the CMMI Days at Home measurement tool. She is a faculty member for the Schilly Institute of Palliative Care and a nurse researcher with research focused on community-based palliative care for patients with COPD and their caregivers. Karen, we're so happy to have you provide this today. Thank you so much.
Thank you. Am I unmuted now? Okay. Hi, everyone. I'm so honored to be able to present on a topic very near and dear to my heart as a patient, as a family member, and especially as a medical provider. So as Annalee mentioned, I do work in palliative care and have had the opportunity to work with many patients and family members who are facing very difficult decisions that they have to make and just conversations that we have to have about their diagnosis and prognosis. So I'm happy to present on communication techniques, how to have a difficult health-related conversation with your patient. So my hope is that at the end of this presentation, you will feel more prepared and confident in being able to have difficult conversations with patients and their loved ones by understanding how to engage a patient and family at the initial consultation, how to approach a conversation about difficult health-related topics, how and why to share difficult information or quote-unquote bad news, and how to actively listen and effectively communicate. Finally, how to verify understanding and plan for the next steps with your patients. So to begin, you have a patient that you need to have a discussion with about their healthcare status and your concerns. You've scheduled a time with the patient. Next, you want to ensure that the key people are present. Read the patient's records, be knowledgeable of the medical history and the situation. Ask if anyone else would want to be present and ensure that they are included in the conversation. You don't want to get halfway through your discussion only to have the patient stop and tell you that she wants to wait for her son or daughter to be present. Additionally, patients will not be able to repeat what you have discussed, and family members will ultimately have questions. When you're meeting with the patient and the other key people, find a comfortable location. These patients are ill. They will need to be physically comfortable in order to even be able to focus. If they are hypersomnolent or in acute distress, such as with pain or nausea, you may want to reschedule for a time they are more alert and comfortable. Next, remove distractions. I often saw patients in their home environments where there would often be televisions or radios on and grandchildren playing in the background, or in a skilled nursing facility or assisted living where there would be lots of activity. My goal was to always remove distractions as best as possible by getting the patient a quiet room where we could focus on one another and what was being communicated. This is also true of hospitals and clinics, of course. Patients often have multiple medical team members coming in and out, and if you could let your team know that you need no distractions during this time, or schedule your visit between meals or med passes, that would be best. Show that you care. Develop a connection. Look around the patient's home. Look at the patient. Are there pictures, mementos, jewelry that you can comment on that may trigger meaningful conversations and give you information about the patient's values? My practice was, as I entered the home or room, I would introduce myself. I would tell them who referred me, why I was there, and then I would find some way to compliment the patient or notice something that would stimulate a conversation in order to break the ice. We are meeting with people ultimately at their most vulnerable. Our goal is for them to feel comfortable. Assure the patient and family that you are there to support them. Again, tell them who referred you, why you're there. Patients have many people calling them, coming into their homes, coming into their hospital rooms, and it can be confusing and overwhelming. They will want to understand who you are, that you're there to support them, and that you're there to add to their care team, not to add stress. So you've got your patient, you've got the key players, and you have removed distractions. Now what? Be a healing presence. The old saying that people may not remember what you said, but they will remember the way you made them feel is especially true in healthcare. Meeting patients where they are, validating their pain or distress, and letting them know that they are not alone and can be a great way to show compassion and also create an environment in which a patient feels safe enough to be vulnerable and to share with you. If this patient is a new referral to you, again, you will want to introduce yourself and make sure that they understand why you're there. Make sure they understand your goals. Next, you will want to assure your patient that this is a conversation you have with all of your patients. You want to normalize this conversation because if your patient feels anxious from the beginning, he or she will retain less of what you are saying and will be less attentive to the conversation. So in preparing for your conversation, you will want to have a plan, but not a personal agenda. I train providers to have a plan for the consultation. What is the goal? Is it that you are able to assess for knowledge gaps regarding the diagnosis and prognosis and add education to fill the gaps? Is it to educate the patient about the care services available? Elicit the patient's goals and transition the patient to appropriate care is another plan, but you don't want to have an agenda. So if you know your plan going into the consultation, it gives you confidence and brings order to that visit. A plan is different, however, than an agenda. For instance, if you plan to transition to the appropriate care service, and in your mind, it is hospice because the patient qualifies and it meets their goals that they've discussed with you, but the patient and family desire to start with palliative care, then your goal is always to honor the patient's wishes, thus making a referral to palliative care to begin with. In order to assess knowledge gaps in patients and areas of need for education, find out what the patient knows and understands. You've introduced yourself, you've told the patient why you were referred. Now it's time to allow the patient to show you what he or she knows and understands. A good way to do this is to say, tell me what your doctor has told you about what is going on with your body. Repeat what you heard the patient say in order to clarify. You may also end up saying something like, can I tell you what I understand about what's going on with your body? But before you start educating the patient, make sure you also understand what the patient wants to know. Some patients want to know what to expect as the disease progresses. Some want to focus more on a prognosis. Some want it in a percentage or a time frame. Let the patient tell you what information would be most useful and use that information to guide your discussion. So what happens when you're meeting with the patient and you have the perfect setup for a successful encounter, but when you meet with the patient or family, you're told that they do not want to discuss end-of-life care or the diagnosis or prognosis. And this does happen quite a bit. One way to overcome this barrier is with motivational interviewing. Motivational interviewing has been used to encourage collaborative communication between the clinician and the patient in a way that encourages an autonomous decision for change by the patient. It can be useful in promoting willingness to have a difficult conversation about one's health status. In terminal illness, having discussions about end-of-life care with patients is an important way to understand and honor their end-of-life care wishes. Though research shows that patients understand the gain or the benefits of having these discussions, many continue to avoid them or remain ambivalent toward them, which results in many Americans dying in hospitals who would prefer to die at home. Framing end-of-life care discussions appropriately is an important way to prevent an unwanted health outcome or death experience, which would result in improved care of the terminal patients. To do this, providers must learn about the patients and their perspectives on death and end-of-life care discussions in general, and then frame the discussions as gains in order to get more patient participation. For instance, you can start by saying something like, I understand talking about this may be scary. I think if we do this together, we can come up with a plan that you will have peace about and will ensure you receive care that aligns with and ultimately honors your wishes and your values. In motivational interviewing, the four key components are engaging, focusing, evoking, and planning. Engaging with the patient means that you establish a working relationship between you and the patient. You're not there to tell the patient what to do. You're there to work as a team. To focus, you and the patient determine the agenda for what will be discussed by discussing the patient's main concern. So again, you may have a plan, but don't go in with an agenda. Find out what's important to that patient. Find out what information would be most useful to that patient. Evoke. Elicit the patient's personal reasons for wanting to discuss the diagnosis and prognosis. Help the patient to find value in the discussion. And then finally, plan. So you shift from why to have the discussion to when, how, who needs to be involved, and what the plan will ultimately be. So you've established what the patient knows, where there are still knowledge gaps, what the patient would like to know, and that the patient is willing to discuss the health status with you. Now it's time to enact therapeutic communication at its best, starting with being an active and engaged listener. As an active or engaged listener, while you're delivering news or educating the patient, you're also watching for emotional and verbal cues that tell you that you need to stop and attend to the emotion before you offer more information. You want to empathize with the patient's feelings. Patients typically retain about 50% of what they're being told in high-stress situations like this due to emotion. So take your time and attend to the emotion. Remain non-judgmental. Again, this goes back to not having an agenda. Ultimately, you want to know what the patient values and honor that. Everyone is unique, so ask open-ended questions that allow patients to fully express themselves. For example, you may have a patient or you may have a family member that you're working with, and the patient completed an advanced directives 20 years ago when he was healthy, and he is no longer in that health state. He has had tremendous declines in his health quality has changed. So you could say something like, I understand that your dad's advanced directives were completed 20 years ago when he was healthy. If your dad knew this would be his quality of life when he completed his advanced directives, what do you think he would say? So it allows for more of a discussion than just a yes or no answer. It elicits more information from the patient or the family member. Being an active listener also means being present. Don't anticipate what will be said, and don't formulate your response until you've finished listening and have taken a moment to consider what was said by the patient. Always assume that you probably don't understand completely. And then clarify for understanding. Ask clarifying questions. This allows for you to be sure you understand what the patient is communicating. It also allows for the patient to hear back from you what you heard the patient say, which allows that patient to clarify or correct. It also allows that patient to further assess his or her own statement and confirm for accuracy. Paraphrase what you heard the patient say and ask if that's correct. And then a very powerful way to connect with patients is connected. Lean forward, touch the patient's hand, hold eye contact, and observe body language. And finally, you want to be comfortable in silence. As a healthcare provider, we tend to want to swoop in and rescue patients in times of silence. Allow for that silence. Sometimes you will ask patients questions and they will need time to think about it. Or maybe they will ask you a question and all you can say is, I'm not really sure about that. And then silence allows for the space to process. So why is sharing bad news especially difficult in healthcare? Generally speaking, bad news is considered any information that changes one's view of the future negatively. So as you can imagine, this would be especially true of a terminal diagnosis or a diagnosis of a serious illness. We would think medical providers are used to and comfortable with sharing bad news with patients as it's just part of the territory, but that is not the case. In our society, care is fragmented. We have a different specialist for each organ system. An infectious disease doctor may be saying the prognosis is good because he can cure the infection. The cardiologist may say the prognosis is good because he can keep the heart pumping. Well, think of these scenarios in the context of the whole picture. In a patient who has terminal cancer, for instance, When specialists are speculating only based on their specialty areas, it can give the wrong impression and also give false hope. An example, my friend's elderly mom was diagnosed with COVID a few weeks ago. I knew from the Facebook updates that the prognosis was not good. However, when the palliative care team came in to tell the family to prepare for the patient's passing that would occur, unfortunately, in the next 48 hours, based on her condition, they were shocked and traumatized by this news. Why did that happen? Because a pulmonologist had come in earlier and said that the patient was doing fantastic as her oxygen was now stabilized on the BiPAP. He failed to look at the whole picture and give the family all of the information. What they heard was, she's doing great. They were not prepared for her passing. Providers are also afraid of failing. Most physicians are trained to address the issue, solve the problem, and fix it. They are taught the problems can be fixed and that is their job. But what about when it can't be fixed? What about when we don't know the cause and we don't know the cure? Many medical providers have a hard time not knowing information or feeling like they have failed their patients. This is ultimately why I went into palliative care. I realized, yes, preventative and curative medicine is absolutely ideal, but what about this large population of patients who need to hear the truth and who need to be heard? How do we come alongside them? How do we support them and educate them and empower them so they have peace about their own healthcare decisions moving forward, and they have a voice in their care that ultimately will lead to their best health-related quality of life? I found encouragement in the results of a pilot study I conducted in my PhD program on patients with COPD and their caregivers. I examined what they found to be the most meaningful components of community-based palliative care. Most of these patients did receive some sort of symptom intervention, but what they found most meaningful was the education that they got from their providers about their disease process, as well as spiritual support. I think the challenge with chronically and terminally ill patients is to understand that their needs may be different and that they will give us grace for not knowing everything and being able to fix everything, as long as we are supportive and we are honest. Discussing bad news is also difficult because in America, we have a fight mentality. I had a friend and colleague who passed away this year from pancreatic cancer. When she was first diagnosed, given her understanding of the disease and treatments, as she was a palliative care provider herself, she chose to forego treatments and transition to hospice care. However, her family really wanted her to try the treatments. She decided to do so in order to give them a sense of peace that she tried. And she said that she was also surprised because she would not have anticipated how powerful her own will to live was. She continued treatments until they were no longer offering benefit and did have a peaceful passing on hospice care. What is important to note is that she transitioned to hospice care on her own accord. Her oncologist said she felt like a failure and wanted to continue to try treatments, which most likely would have negatively affected my friend's quality of life. When I work with family members who have a hard time accepting that their loved one wants to focus on quality of life and forego any further treatments that might prolong life, I explain that we are still fighting, but what we are fighting for now is for the best quality of life for as long as that patient is still with us. And what if a patient shows emotion? Many healthcare providers are not trained to attend to emotional responses of patients. Tears are not an emergency that must be stopped. I remember a doctor literally walking backward out of an exam room and telling me to talk to my friends when I broke down and cried in her office. I give her grace, and also in my mind thought to myself at the time, I don't ever want to make a patient feel like that. What a difference she would have made in my life, and how different my memory would have been of that experience if she pulled up a chair, looked me in the eyes, and took 5 minutes to say, "You're not alone, we'll figure this out. Tell me what you're feeling." Another experience I had was my OBGYN calling me when I was 30 weeks pregnant with my daughter. She told me that she had found labs in my chart that had been done by another provider. She told me that my daughter had tested positive for trisomy 18. I had no medical knowledge at the time. I asked what this meant, and she, over the phone, told me that my daughter would not live more than an hour after birth and that I should Google it. My daughter had a name. She had a nursery, a place in our family, and a future in my mind. My world shattered in those moments, and I was alone with no education or support from a medical provider who could have helped me process and prepare properly. Thankfully, it was a false positive. My daughter was not, in fact, trisomy 18 positive. This experience, like the other, though, taught me a lot about how I never want to break bad news to patients and their families. You can instead say supportive things like, I know this is not the news you were hoping for, or I can only imagine how getting this news feels, or I wish I had better news. And then be sure that they know they're not alone and that you are available to answer any questions that they have. It's also helpful as clinicians who care for terminally ill patients specifically if we acknowledge within ourselves that we all will one day die. We can't enter into meaningful, supportive conversations with patients if we are afraid of death and dying ourselves. We need to explore what it would feel like to be in the shoes of our patients. And finally, the tension between autonomy and paternalism. Historically, clinicians have been, quote unquote, the wise healers, and the patients the passive recipients of the care. But in our society today, patient autonomy is the gold standard, and patient choice often dictates the care. For the most part, I honestly agree with this approach. The caveat is that the patients need the wisdom and education from the clinicians in order to be able to make informed decisions about what care they're truly comfortable with receiving. There was a shift from paternalism to autonomy in the 1950s with the advent of informed consent. The combination of informed consent and an increased access to medical information by the general public led to a patient's participation in medical decision-making, which is a good thing. But again, the pendulum may have swung a little too far in the direction away from doctor knows best, with many clinicians abdicating their medical expertise to defer to the patient. Central to paternalism is truth-telling. Some people ask, why tell someone the truth of their condition if the inevitable is just going to happen? Well, we aren't being honest with patients if we don't tell them their prognosis. If we don't educate them about what to expect as their condition progresses, it doesn't allow them time to plan or grieve. As medical professionals, we commit to not only non-maleficence, but beneficence. Not only should we be intentional about doing no harm, we should be equally intentional about providing benefit. It could do harm to not be truthful with our patients. Most patients that have a terminal illness have an innate sense of what's going on. What they're really looking for is confirmation, support, and guidance. A more balanced approach in medical decision-making that may solve the tension between paternalism and patient autonomy is called shared decision-making, which involves the clinician-patient communication in medical decision-making and has been described as a continuum. The shared decision-making continuum has the clinician decision-making on one end and the patient decision-making on the other end. Where the decision-making lands in the continuum is different for each patient based on personality, comfort level, and need. This is why clear communication between the clinician and the patient is imperative in order to find that balance. The burden of decision-making, typically in a crisis situation in our society today, the clinicians look to the patients or family members to make those decisions. This is often due to what is called defensive medicine. Clinicians may also be afraid of limiting options for decision-making in critical situations as they are afraid of litigation. But the opposite is actually true. Clinicians are more likely to be sued for pursuing aggressive treatments when that was not the wish of the patient. Also, handing decision-making over to the patients and families in a crisis is often not what they desire, as no one wants to be responsible for pulling the plug or causing death. Patients and family members typically want the physician to explain that due to illness, the outcome is inevitable, and this is what I suggest, or these are your options. This is why having goals of care and advanced care planning conversations with patients and family members before a crisis is best practice. There is less stress and complicated grief if decisions are made on the front end. Compassionate guidance in the form of a recommendation is usually what patients and family members desire from their medical providers. Furthermore, as they say, honesty is the best policy. Sharing treatments with patients that are unavailable or unlikely to have any positive outcomes for patients only increases suffering of the patients. It is only in being truthful and sharing our expertise, advice, and wisdom with patients and their families that we equip them with the information to allow them to make decisions for their own care moving forward in a way that is empowering and aligns with their wishes and values. Most will want some sort of prognostication or time frame. A good way to approach this is to say, if I saw 100 patients in your condition, this is what I would expect the average outcome amongst the patients to be. We can never prognosticate perfectly, and we should be honest about that. But we can be able to say things, well, we should be able to say things like, if I had to give you a time frame based on my clinical experience, this is what I would guess that the range would be. In finishing up your discussion, you will want to have a plan of action. Ask the patient what he or she understands now that you've had a chance to have a conversation. Make sure the patient understands diagnosis and prognosis. What can be fixed? What can't be fixed? What makes sense as far as treatments? What doesn't make sense as it may deplete your quality of life? Paraphrase back to the patient what you heard him or her say. Allow the patient the opportunity to correct what you heard. Add any additional information you feel that needs to be highlighted. And again, always be honest. Discuss the plan for next steps. What happens now? Do you schedule a time for a follow-up discussion? Is there a care transition that will occur? When will the patient hear from you or see you or another provider again? What should be done in the meantime? Who does the patient call with any follow-up questions? Have the patient repeat the plan back to you. Confirm that the patient doesn't have additional questions before you close the visit. Once the patient understands the diagnosis and prognosis, understands the plan, this is a good time to schedule a visit to discuss advanced care planning and goals of care if it hasn't already been done. Also, this is a good time to assess if it would be appropriate to refer the patient and family to additional care services like chaplaincy and social work to continue to support them through the grief and mental, emotional, and spiritual processing of the new information and planning for the future. Thank you for your time. I hope that this presentation has helped you understand how to approach difficult conversations with patients. Just remember, be authentic, be honest, respect the patient's wishes, and it's okay that we don't know everything and can't fix everything. We can share in decision-making and guide patients while also allowing them to be autonomous in their healthcare decisions.